This is on behalf of colleagues working in Bath and North East Somerset Clinical Commissioning Group, where I also work 3 days a week as a commissioning pharmacist. We've been running a quality improvement programme over the last 3 years to try and improve the management of UTIs in our whole nursing home care population. And we have used an evidence-based systematic approach to improve how UTIs are diagnosed and managed in all our residents. When we started our 23 nursing homes, we're now down to about 20. We didn't include residential homes at the time, although we will now be looking at how UTIs are managed in residential homes in the light of this quality improvement programme. So this was delivered by our care home pharmacist service working during 2015-16. It was aligned to our GP enhanced nursing home service. So the architecture made it easy because we had primarily 1 or 2 GP practices aligned to every nursing home, and we mapped our care home pharmacists on top, and so there was great clarity about who was responsible and who needed to work together. It was funded by the CCG as a quality improvement project back in 2014 for something under £10,000, which was really to pay for the extra time from our care home pharmacy service. So why did we actually think about doing this? Well, local clinical audit in 2013 had identified that residents were frequently prescribed antibiotics, up to half of our residents in one care home, based on the practice of urine dipsticking. Which I'm afraid, Lisa, guidelines do not support in the older population. And as one microbiologist said a year ago, you might as well save your dipstick money and throw a 50p coin in the air, and heads or tails, you've got a UTI. I didn't make that up. So in that elderly population, they are extremely likely to have bacteria in their urine without a UTI. And in fact, we were alerted to the fact we might have a problem when we were looking at our routine antimicrobial prescribing data for primary care. This was before the AMR quality premium, when I was very concerned because in Bath and North East Somerset, we had a very high proportion of then cephalosporins and quinolones. And you can see this is a scatter plot of our volume of antibiotic prescribing up the vertical axes against the proportion of cephs and quins. This was before we added coamoxiclav in. And this was all 7,500 GP practices in England, with the practices in Bath and North East Somerset mapped on top and quintiles put on. And you can see that practice way over there on the right-hand side, sort of floating off the edge of the graph, who, as it turned out, was providing superb compassionate care to a very large dementia care home, providing end-of-life dementia care. And so what we did was we had a meeting with the we had a meeting with the practice, with the microbiologist, with the consultant for older people from the local hospital, with their practice pharmacist, their care home pharmacist, their community pharmacist, their CCG pharmacist, all the practice staff, the practice manager, the practice nurses, so everybody got in the room. And actually we had a really interesting discussion about end-of-life care, is what it turned into. And it turned out that the care home staff had very little else to offer these residents who were quite often double incontinent, very demented, couldn't communicate easily, their behaviour would deteriorate, and they would have nothing left to do apart from say they've got a UTI, let's give them some antibiotics. And quite often the patient's relatives were very anxious and upset and were wanting something to be done about the distress that the patient was in. So it was coming from a really strong desire to help the patient. But actually it really wasn't. And so early evaluation, and I'll go through the results in more detail, but early evaluation showed that when we rolled this out across 8 of our nursing homes, we had a 56% reduction in the proportion of residents who had an antibiotic for a UTI. And when we looked at all of our post-evaluation at all 23 nursing homes, in fact, 143 out of 690 residents had at least one antibiotic for a UTI in the 6-month period. Now, that 143 was about the size of the patients getting an antibiotic in the 8 homes we looked at pre-implementation. We had a 67% reduction in the number of antibiotic prescriptions used. And really importantly, we had an 82% reduction in the number of residents prescribed antibiotic prophylaxis. So we had less patients after implementation in all of our nursing homes on antibiotic prophylaxis than we had in the 8 we started with at the beginning. We were really concerned we might be causing harm. I was very concerned we might cause unintended sepsis, and we were monitoring patient admission to hospital. And we were really surprised, looking at Sarah here, to find that our admissions went down for UTI, urosepsis, and acute kidney injury. Acute kidney injury, we put very, very strong hydration messages into everything we did, and I think that has contributed to that, as well as improving management of the UTIs. So this is the really busy slide showing our data. So what we have is we have pre-intervention data, starting off on the left-hand side, in our 8 nursing homes, and post-intervention data in our 8 nursing homes 6 months later. But we also collected all the data in the post-intervention phase for all the other nursing homes, so that's the middle column. We have since, at the request of the CCG, made this routine everyday business for the care home pharmacy service, and they are now collecting this data every 6 months. So we also have, on the far right-hand side of the screen, the last 6 months' data that we've just captured and started analysing. And out of this, we've come up with some metrics. So one of the metrics is the number of residents who are prescribed 1 or more acute courses of antibiotics out of all the residents in that home. And you can see that has reduced from 43% at the beginning down to 21%. But really interestingly, although we have not re-educated or done anything different, we have sustained that reduction over the last 6 months. The number of acute courses of antibiotics prescriptions out of all residents prescribed an antibiotic prescription. So some idea of how often are they getting antibiotic prescriptions for their UTIs. And you can see that that number has stayed about the same, I would argue. In the 8 pre and post, we obviously had a big relative reduction, but now we're staying the same. So we've sustained that reduction. And then the proportion of, or the number of residents who had prophylaxis. And of course, some of those people would also, on top of their prophylaxis, be having some top-up acute treatment courses of antibiotics, in some cases as many as 5 and 6 months for the odd patient. And again, we have sustained that reduction in the proportion of residents having prophylactic antibiotics. We've also, in the last 6 months, captured the use of catheters in the residents because we had identified cavties, but we hadn't got that in the context of, well, what was the catheter use like in the nursing homes? So this is very hot off the press data. It's not completely entire, but I think it's still pretty robust. We've not got an awful lot. I think we've got 1 home left to come in. So 60 residents had a urinary catheter at some point during that last 6-month period, January to June 2016. So that's 60 out of the 700. And 28 residents had 45 CAUTI events out of those 60 residents. And of those 26 residents with indwelling catheters had 1 or more acute courses, and the number of courses was 41. And 2 residents using ISC had 1 or more acute courses, and the number of courses was 4. 3 residents were prescribed antibiotic prophylaxis for UTI due to an indwelling catheter. They also continued to have catheter-associated UTIs. We're encouraging, this has been widely shared already, this quality improvement programme around the country, and I know Annie is here from Nottingham today, and they've got some funding to roll this out across 5 CCGs, and we're trying to encourage capture of some core metrics so we can start to compare data, because what I don't know is what would this look like somewhere else? Is this good? Is this bad? Were we really dreadful to begin with, and actually everyone else has been trundling along at that lower figure of 21% of care home residents, and it was just Bath and North East Somerset doing it differently? And we won't know until we start to share data. So you're probably wondering, what on earth did we do? Well, first of all, I think we use clever commissioning. We're not the commissioners of nursing home care, that's the council, but we are the providers of NHS care. And so we used a shadow sequin with our nursing homes as part of a wider programme of interventions, and they were really, really keen to engage. So that wasn't a problem. We had a care home pharmacist team that already existed, And so it was relatively easy to get extra funding and extra time to deliver the intervention. I should point out that most care home pharmacists are not involved in antimicrobial stewardship in my experience. They're really interested in prescribing and polypharmacy, and I'm trying really hard to point out that antimicrobial stewardship should be a core element of their service. We introduced new documentation and we educated all of the nursing home staff. So we used Sign 88 guidance to structure documentation. I'll show you what that looks like in a minute. And we used our care home pharmacists to develop that as an educational bundle in all of the nursing homes. And we started that with very strong hydration messages everywhere we went. We communicated with everybody, but clearly you always feel you could have done that better. We identified some amazing cans of worms, like our lab in Bristol would not accept a urine sample for culture from the care homes without a dipstick first. And our out-of-hours service provider would not go and visit that care home out of hours without a dipstick first. And in fact, our own bladder and bowel service had their protocol started with please urine dipstick. So we had to undo a lot of this dipsticking built into people's processes and procedures. We monitored for unintended harm and we evaluated. We are now in the process of updating our documentation because, as with any quality improvement program, it's really a continual improvement process. But that is the form that we used to try and encourage care home staff to use the evidence-based clinical symptoms to assess the patient. That form was then faxed through to the aligned GP practice, and that meant we had a documentation for the GPs to work on. And the GP could then fill in section 5 and come up with their management decision. The idea was this form would then be scanned and recoded into the GP records. Well, I can tell you that definitely didn't happen, so we've got room to improve there. But the form was used, the dipsticking reduced. We also provided laminated guidance, so there's the SIGN algorithm and the Public Health England or guidance for diagnosis, which has since been updated in May last year. And we provided these resources to put up in clinic rooms to try and remind staff what was appropriate. So what we're doing next, well, as I said, the CCG has said that this has now become everyday core business for the care home pharmacists, but we're actually going out to re-educate our nursing home staff with an amended documentation to try and improve compliance with the documentation, but with acute kidney injury messages integrated as well. So we're using the Think Kidneys, fantastic resources. If you haven't looked at their site, please do so. They have a care home resource site on their website, and we're going to be building those in as well. Because 1 in 5 unplanned admissions is thought to be due to acute kidney injury. A large proportion of those will be due to UTI. We changed the documentation, we provided education. As I said, we're reviewing this, and we're going out to re-educate. We communicated with everybody, but we definitely could have done that better. But we've also shared our data quite widely, and that's been really helpful because we didn't actually know what was going on until we started sharing our data. And what we're moving towards now is developing key metrics in a run chart for every nursing home, so they can actually compare themselves with the other nursing homes. That's proving a bit challenging because how do you quantify the population in a nursing home where you have really quite a high turnover of residents? And we're using quality improvement methodology to make small changes and then evaluate those for effectiveness. However, I wanted to share some data on having implemented this reduction in inappropriate antibiotic prescribing, what were the antibiotics that were being used at the moment or are being used at the moment. Now, this is data from July-December 2015. It's really very similar to the data we've just had out of our last 6 months, so I haven't even bothered to update the slide because we're still using an awful lot of trimethoprim. And that trimethoprim is being used in patients for whom we have no sensitivity data, we have no previous sensitivity data, and they're still not sending urine samples off for culture. So effectively, we've got a lot of inappropriate management still going on because they're treating blind. Interestingly, the proportion of comoxiclav prescribing didn't change as a proportion of what was used, but prior to this intervention, all the co-amoxiclav prescribing was guideline non-compliant. Afterwards, half of it was guideline compliant. And we think what had been happening was that care home staff had been dipsticking and the GPs had been sending off a prescription for trimethoprim. And the patient probably had an upper UTI and they went on to develop urosepsis and were admitted to hospital. Now we're seeing co-amoxiclav used and quinolones used appropriately, but mainly co-amoxiclav used appropriately to treat upper UTI. So we've also seen an increase in appropriate prescribing, which is really heartening to see. But clearly we've got a whole load of room for improvement. So just to summarise, we use an evidence-based algorithm. We've been very systematic about our approach. We've seen a significant reduction in the use of inappropriate antibiotics, and I would really recommend you consider looking at the management of UTIs in your nursing home population as part of the quality premium for next year, because it could be a really big gain in terms of improving patient safety, reducing the unnecessary use of antibiotics and reducing some of the drivers to resistance in that very vulnerable patient population. Some of the nice round the edges that came in is that the GP said they had reduced calls to practices from care homes for inappropriately diagnosed UTIs. And in fact, the GPs were actually sending our complaints email address at the CCG emails saying, would you please tell out of hours to stop demanding dipsticks? And did you know so-and-so's doing this? They were really engaged, so we had really quite good GP engagement in that aspect. We just couldn't get them to scan the documentation into their records. And include hydration messages within the educational content. That was the simplest and cheapest and easiest intervention to introduce. So this has been published as an innovation poster back in 2015, shared widely, as many of you will know. I'm in the process of setting up a community of interest, probably using Kahoot, to support learning and benchmarking so we can make it really easy for people who are adopting and adapting and improving this to share, so that we also in Baines can learn from other people's improvements. It was presented by the NHSI Patient Safety Team at the IPC Summit that launched the government's aspiration to reduce E. coli bacteremias by 50% by 2020. So this is very much on the national agenda. And I'm really proud now to be able to say that antimicrobial stewardship is now a routine care home pharmacist role. And if you are interested, you can use the hashtag to dip or not to dip, which is the name that we're giving to this intervention.